Thank you, Dr. McLemore. That was star-studded. Thank you all. What a great workshop this is. So I have the extreme pleasure. Oh, well, first of all, I'm a professor and OBGYN at Northwestern Medicine in Chicago, and I'm the founding director of the Center for Health Equity Transformation and the Chicago Cancer Health Equity Collaborative. And in this session, we're going to be hearing about experiences of birthing people during this unprecedented period of COVID and the experience with technology to provide and receive services. Our first speaker in this session is Dr. Stephanie Gaw, who is assistant professor in maternal fetal medicine at the University of California, San Francisco, UCSF, and the co-principal investigator in the COVID-19 Priority Study, which stands for Pregnancy Coronavirus Outcomes Registry. Thank you, Dr. Gaw. Please take it away.
Hi, thank you so much for the introduction and the opportunity to speak to you all today. I am actually speaking on behalf of my co-PI, Dr. Yelda Afshar, who had a last-minute conflict and was not able to be here today. Next slide. So, we have come a long way since the beginning of the COVID-19 pandemic, even though it seems like it's never ending. Very early on in the New York Times, there was a report of this, the first 147 women that had COVID-19 during pregnancy that was buried in a larger report from the WHO published on February 28th. And in that analysis, they reported that it did not seem like pregnant people had any higher risk of severe disease from coronavirus, as only 8% had what they called severe disease and only 1% were critical condition. Next slide. And I think this really reflects how little information we had at the time. So our guiding professional organizations, ACOG, their first clinical practice advisory released in March 13th of 2020, stated that currently available data on COVID-19 does not indicate that pregnant women are at increased risk. And this really was a reflection of the complete lack of data at that time as we were embarking on the epidemic here in the United States. Next. And then as data slowly came out, or actually I should say quickly came out over the next few months, the practice advisory was revised a couple of times, and in December stated that yes, indeed, available data suggests that pregnant women with COVID-19 may be at increased risk for more severe illness compared to their non-pregnant peers, and that the CDC now included pregnancy as a group with increased risk for COVID-19 illness. Next slide. So there's so much data that has come out over the past year on COVID-19 in general and COVID-19 in pregnancy specifically. It's really hard to sift through all of it. I did want to focus on this work that is being led by the World Health Organization by John Allotte, which is a really important project. I think it's the Pregnancy and COVID-19 Living Systematic Review and Meta-Analysis. So this is a WHO-sponsored working group, and they early on set out to try to, in as much real time as possible, try to synthesize all of the COVID-19 and pregnancy literature globally to more rapidly give us clearer answers on what the true outcomes are of maternal and perinatal COVID-19 disease. And so what they do is that they include all COVID-19 cohort studies in pregnancy in all languages across the world. They have very rigorous literature review. They they search through multiple international databases. All languages are included. And their plan is to make this a living systematic review, and that they plan to do multiple updates for up to 2 years. And these updates are then published in the BMJ. The original publication was published on September 1st, and at that time it included 77 studies. And then the first update was accepted on February 2nd, and I think published a few weeks after that. And you can see that it included almost 3 times as many studies as in the original 192. Next slide. And so of these 192 studies, 30% were from the United States, and I would say the largest cohorts are probably from the United States. 16% of the studies were from China, and you can see the other leading countries that contributed data. In this first update, the second publication, there are almost 65,000 pregnant or recently pregnant people that are included. And of these, 92 studies specifically looked at maternal outcomes, and 95 studies looked at pregnancy-related maternal outcomes. And just to give you a sense of kind of the heterogeneity in these sample, in trying to interpret the literature on COVID-19, both in the United States and globally, just the sampling of these patients, 89 studies represented patients that were diagnosed based on universal testing, which is not standard in many parts of the world. 25 studies used risk-based guidelines, so a combination of epidemiological risk factors and symptomatology. 32 studies reported just symptom-based testing, and 46 studies did not report their sampling mechanism. And overall, when they compared maternal outcomes with COVID-19 and pregnancy versus non-pregnant people with COVID-19, they did see that there is indeed an increase in severe disease. There's a 2-fold increase in ICU admissions, a 2.6-fold increase in invasive ventilation, and a 2-fold increase in ECMO and other measures of severe illness. Next slide. And looking at perinatal outcomes specifically, and so the comparison group here is against pregnant people without COVID-19 disease. And of note, some of these comparisons, some of the studies use historical cohorts to compare, and others use contemporaneous cohorts. But there is obviously a difference between the two based on all the practice changes that we've seen with during the pandemic. But there does seem to be an increase in preterm birth, less than 37 weeks. There was an overall rate of 17% of preterm birth in people with COVID-19 in pregnancy, of which 6% were spontaneous. So that suggests that it's probably due to severe maternal illness and medically indicated preterm deliveries. There was no significant difference in cesarean delivery globally. There does seem to be an increase in the rate of stillbirth, although the overall numbers are very low. An increase in neonatal death, NICU admissions. Next slide. And when they looked through all the international data for factors that are associated with increased risk for severe outcomes, this is a very busy slide to show that all the usual suspects, increased age, increased BMI, non-white ethnicity, and medical comorbidities were frequently associated with different measures of disease severity in COVID-19. Including ICU admission, invasive ventilation, and maternal death. One major limitation of this part of the data is incomplete reporting from many of the studies, but I believe that the majority of this data, the majority of the patients included in this data to date are from the United States and the United Kingdom. Next slide. And so the overall strengths of this meta-analysis is that it is, a very rigorous study of all available international studies, and that they are doing continual updates at pre-specified intervals over time to try to give us the most up-to-date synthesized information on COVID-19 internationally. The limitations are, of course, the heterogeneity of the studies and the cohorts and the data. Their team, I know, does a lot of fact checking to try to reduce the number of duplicate reporting from different studies and different study sites in different countries. As of now, most of the outcomes reported in pregnancy and COVID-19 are primarily from hospital-based diagnoses, and this is largely due to the widespread universal screening of all pregnant people on admission to labor and delivery in the United States. And so this is not necessarily reflective of the overall COVID-19 experience for the majority of people who are not admitted to the hospital when they contract the illness. Of course, we are all awaiting more data on first trimester infections. In reviewing the studies, there was definitely a need for more studies with contemporaneous pregnant comparison groups. As we all know, the prenatal care and medical care, hospital care, and access to care has changed so much during this pandemic that it is difficult to reliably compare with the historical comparison group for a lot of these outcomes that for which access to care has a significant impact. Next slide. And so my colleagues and I in March of 2020 launched the Priority Study, which is a nationwide cohort of COVID-19 infection and pregnancy. Next slide. And the Priority Study is a really large study. We include all pregnant people over the age of 13 who are pregnant or pregnant within 6 weeks that are under investigation or with a confirmed diagnosis by RT-PCR of COVID-19 since January of 2020. Participants can enroll in any language from any site across the country, whether it be private practice, academic hospitals, midwifery practices. And if they are medically unable to self-consent, for example, if they're ventilated, then a family member can provide proxy consent. There are 4 outcome cores that are listed here: the maternal outcomes core, the infant outcomes core, the reproductive health equity and birth justice core, and the biospecimens core, for which I am the lead PI on. And the goal of these 4 cores is to provide comprehensive data on the medical and clinical outcomes from COVID-19 in pregnancy, the infant outcomes up to 1 year of age, both the clinical outcomes and the patient experience of BIPOC people during the epidemic and getting care for COVID-19, and then also to try to understand some of the biologic roots of disease and disease severity. Next slide. And so as far as the overall study design, there were 3 ways that patients could enroll: by self-referral, through provider referrals, or through our community partner referrals. They enrolled through the Central Coordinating Center at UCSF. And the study is comprised of weekly questionnaires for 4 weeks after enrollment, at each trimester, at term, and at specific time intervals after the end of pregnancy. Medical records are also reviewed for every participant. That includes hospitalizations, delivery, and neonatal outcomes. The mother-baby dyad is followed through 12 months of age. In parallel, there's the Priority B, or Priority Biospecimens study, which is an overlapping and parallel study that is run at 6 different hospital sites across the country, for which we are collecting biospecimens for further study on the disease transmission and immune response in the mother-infant diet. Next slide. Oh, thanks. So I wanted to draw a little bit of attention to the RHE and BJ core that is led by my colleagues listed here, including Dr. McLemore, who's at this workshop. But this core has been, I think, a really special part of the priority study in that they, have worked to engage in an authentic and meaningful way the BIPOC communities that are disproportionately affected, not only by COVID-19 diagnosis, but the worse outcomes from COVID-19. And this is done by supporting increased enrollment of BIPOC participants, targeted survey instruments to understand their individual experiences with racism and access to care during COVID-19, the establishment of a National Community Advisory Council, and as well as RPAC groups to help prioritize research questions that are of interest to the communities most impacted by the COVID-19 pandemic. Overall, this is from our priority dashboard, which you can access on the website, but we closed enrollment at the end of September 2020. There are over 1,300 participants enrolled. You can see that in the blue bars, the representation of infection across pregnancy is good. We have enrolled from every single state minus North Dakota and Arkansas in the United States. And as far as our race and ethnic diversity of our participants, we have approximately 49% of our participants are white, and the rest were of non-white ethnicities. We are currently collecting data to finalize the pregnancies. I think the last due date was the end of April, so we're still waiting to hear what happened with those final pregnancies delivered. Next slide. And I'll just very quickly, we have published 2 papers so far. The first paper was published in the fall of last year, showing that COVID-19 did have a prolonged course of symptomatology, and about 25% of pregnant people still reported symptoms after 8 weeks. And of note, approximately 95% of our participants are not hospitalized. So this is very representative of the general experience. Next slide. The report of the first 263 births showed that there were no significant adverse outcomes in these pregnancies. Next slide. And coming soon, we are still collecting and analyzing data for the final, but we do await maternal outcomes data, our complete neonatal outcomes data. We are doing neurodevelopmental assessments of the infants at 6 and 12 months. Dr. Brittany Chambers is leading the Priority Voice study, which is interviewing about 40 birthing people to explore their personal experiences with maternity care. And then the biospecimens core has enrolled over 300 participants that have donated biospecimens. And I will just wrap up next slide to say thank you to the team, which is huge. And next slide and also to our partners. Thank you very much.